Good afternoon, everybody. I hope you can all hear me. Welcome to this session entitled Vaccination and Transmission Control. My name is Stefan Ehlers. I will be chairing this session. Let me just put this up here so I can see everyone. After a few introductory remarks, I'm going to introduce the speakers and the topics of their talks to you and give you an outline of the session. I'm the Chief Executive Officer of the Research Center Borstel, which is located near Hamburg in Germany. And you might probably best have heard of it as the lung research center of the Leibniz Association, who is actually one of the sponsors of the World Health Summit. The Leibniz Association comprises 96 institutes, and their mission is research in social, environmental, engineering, and the health sciences. Leibniz institutes are funded by the federal and local states. They undergo regular external evaluation, and they combine scientific excellence and relevance of their research for society. Many Leibniz research institutes have teamed up to form highly interdisciplinary research alliances. For example, one consortium called Infections 21, which looks at challenges by infectious diseases in the 21st century. One of the topics, of course, is control of transmission of infections. And another consortium is called Innovative Health Technologies, and they develop point-of-care diagnostics, for example, of antibiotic resistance. Now, concerning this session, let me start by saying that it is not about COVID-19. Although you will find that the impact of COVID will, of course, be felt intensely, not only because this is now an online-only session, but also because of the repercussions COVID-19 has had and will continue to have on the topics that we will address today. For the next hour and a half, we will be looking at what's new and what works best in preventing infections. And we'll have 10-minute presentations by the following speakers. Stefan Kaufmann will talk about the vaccine he has developed against tuberculosis. Marilyn Addo will talk about her experience with developing and implementing a vaccine against the Ebola virus. Klaus Cichutek will talk about current challenges for regulators when accelerating vaccine development. Stephen Sinkins will talk about dengue virus transmission and how that can be reduced by using infected mosquitoes. And last but not least, John Amwasi will talk about how implementing malaria control measures has to stay top of the list in Africa. All of the talks will address or will try to address these issues concerning efficacy and safety of new vaccines and vector control regimes. They will try and deliver take-home messages for what has worked best and what has been learned from mistakes in the past, so that we may capitalize on this knowledge gained to accelerate developments, to improve maybe common avenues for controlling infections, and most of all, strengthening local capacities so that great improvements won't get lost in implementation. After the 10-minute talks, after each 10-minute talk, there will be just a short question and answer session to clear anything that has not been entirely clear from the presentation. But after all of the talks, after the 10-minute talks, we should have about 20 minutes to discuss all these issues that I've put here on the slide jointly. So I will now ask the first speaker, Stefan Kaufmann, to share his presentation. Stefan Kaufmann was until very recently the director of the Max Planck Institute for Infection Biology in Berlin. And he has worked his whole life to understand the immunology of TB and has used this knowledge to create a vaccine based on principles of the host biology when digesting mycobacteria. He has come very far in this endeavor, and his vaccine is currently in phase 3 trials. So Stefan, please share with us your thoughts on what works well and what doesn't in TB vaccine development.
Okay, thank you. I assume you can hear me well and the slides are on. So let me start immediately. I will start actually with a paper that appeared in Nature a couple of years ago, where they compared the different types of infectious diseases and how many people have suffered and have been killed by those. And as you see immediately, tuberculosis was the #1 killer. If you look at the last 200 years, with 1 billion or more cases, that's more than smallpox, malaria, plague, influenza, cholera, AIDS together. So TB is a big problem. And you could argue, of course, this is a matter of the past. Unfortunately, it is not. And even today, TB is a #1 killer, maybe overturned soon by COVID-19, but it is still amongst the major killer amongst infectious diseases. So there is a vaccine against tuberculosis, and that's BCG, and much hope had been given to that. But unfortunately, BCG does not really protect people at older age, and notably, it does not protect against tuberculosis of the lungs, pulmonary TB. It's very effective, although not completely effective in neonates, where it protects against extrapulmonary TB. But obviously, we need a vaccine that protects against pulmonary TB, not only for the sake of the people who get the vaccine, but also for interfering with transmission, because obviously, as we all are aware, the lung is the major port of entry, but also the major port of exit for many pathogens that are transmitted via the air. We came up with a vaccine that is based on BCG because we thought, why not take all the advantages of BCG, but we made it more efficient and safe. And I will not go into the details how we did that. So it's a genetically modified organism which had shown safety and no toxicity. And then a very important technical step was initiated, and that is large-scale production under GMP conditions. And that is very important because it's done by fermentation, which allows us, and that's a very important step forward. Also, it's not a real scientific step. It can be scaled to any doses you need. That means millions to billions of doses because it's in a high throughput bioreactor system. Has been licensed to a small German broker-like institution, the Vaccine Project Management, and then sub-licensed to the largest producer in the world, the Serum Institute of India. And when I say largest producers, I mean largest producer by doses. And mostly all of the vaccines, or many of the vaccines from Gavi, come from that producer. We had 2 phase 1 trials, one in Germany, South Africa, successfully completed. So the vaccine is immunogenic and safe. Then 2 phase 2 trials in South Africa, the last one in HIV-exposed neonates. Again, the vaccine is safe and immunogenic. And now we have started 2 phase 3 trials for efficacy trials, one in India to prevent recurrence in patients of TB who had been cured. But in India and many other high incidence countries and prevalence countries, about 10% of those who had been cured by drugs will redevelop or undergo recurrence, and TB comes up again, be it through reinfection or through relapse. And what we want is to interfere with this recurrence by vaccination. The study should be completed with people recruitment, and hopefully we get the data on this next year. And another large study has been is ongoing, which has been introduced and is under the umbrellaship of the Indian IMCR, the Indian Medical Research Council, ICMR, sorry, and that is against household contacts, to protect household contacts of TB incidence cases. So someone is diagnosed with TB and household contacts are then included if they agree to do so in the phase 3 trial. And a last phase 3 trial will start hopefully later this year, but latest new year. It was already supposed to start mid-2020, but there were delays for the obvious reasons of COVID-19. And that is a large study, which is based on our phase 2 trial in HIV-exposed and unexposed neonates all over sub-Saharan Africa, 7 different sites. Okay, that's more or less what we wanted to say about our VPM-1002 vaccine based on BCG. BCG is also used for treatment of bladder cancer, and it's currently tested against COVID-19. In bladder cancer, it is a treatment of choice, and this is important because very, very high doses are tolerated in most cases. If we think of BCG or any vaccine immunity, we first of all think of acquired immunity in bladder cancer, but also probably in defense against COVID-19, we have to focus on innate immunity, because in the bladder cancer situation, the BCG is given into the bladder where it activates innate immunity. Innate immunity is being trained, and therefore the phagocytes and the innate lymphocytes and the NK cells are much better in protection. So I think that's important, because I think that this so-called heterologous protection also works against COVID-19. And indeed, there are a number of evidences that BCG could provide a heterologous protection against viral infections. I'm not going into the epidemiological data. I would call them hypothesis-generating observations, and we now need controlled trials. And actually, there is one controlled trial that has been completed. That was a BCG revaccination study that was completed 2018. And most people oversaw it, including myself. But if you look carefully at the side effects, what you see is that in that group of individuals who got a booster with BCG, adult individuals, 25 developed upper respiratory tract infections, whereas in the BCG control, only 7. So there was about fourfold protection against, or acquired, or resistance, against this infections with virus in the respiratory tract. That has been repeated and even strengthened in adults. But this is not coronavirus, obviously. These are other viruses, mostly influenza virus. So there are now controlled studies going on BCG in many countries. I just mentioned 4 of them: Netherlands, Australia, South Africa, USA. First of all, to protect, to see whether uninfected healthcare workers can be protected, but also whether elderly and other people at high risk of severe disease would be better off if they got a BCG shot. Let me just now come to the drawbacks and the pitfalls of BCG. It's not reliable in protecting against TB in adults, that I already mentioned, but also some bladder cancer patients do not respond to BCG treatment adequately. Moreover, it is still produced as it has been produced 100 years ago, so it is not scalable. And WHO is very eager to see that the doses that can be produced, we had already bottlenecks, 130 to 140 million doses are used to protect neonates against TB, against extrapulmonary TB. So there are clearly drawbacks for BCG, and that's where we think BPM 1002 is also a kind of an alternative to BCG. First, it's based on BCG. We have already excellent safety and efficacy profile in preclinical and early clinical studies. And notably, it can be scaled up to millions or billions of doses by Serum Institute of India. So we think that this is a candidate, and indeed to replace BCG. And indeed, in those individuals in a clinical phase 2 study who did not respond adequately to BCG and therefore could not be given BCG, BPM 1002 showed a 50% recurrence-free over 60 weeks. I think that's very impressive, because it was done in those individuals where BCG did not work. And now a study is planned for individuals also instead of BCG to see whether BPM 1002 can be used instead of BCG. And also a phase 3 trial is ongoing in Germany, in India, and Canada with BPM 1002 to see whether there can be some heterologous protection induced by BPM 1002. And for obvious reasons, because of the high incidences of COVID-19, this study is particularly important in India. So let me summarize with 2 more general issues. I think TB and COVID-19 have certain similarities, although they are caused by different agents. but TB can offer clearly a long-standing interest and experience in basic research and in R&D. And COVID-19 obviously has taken all the interest and therefore accelerated implementation of R&D, of control mechanisms. Substantial funding had been gathered, and experience, of course, of CEPI, Gavi, and the WHO, notably in the context of COVAX, is extremely valuable. And I think TB research, BCG, and other vaccine research can clearly profit and benefit enormously from these recent advances. However, there are also some drawbacks, and I would like to point out that already today, disruption of TB lab services and drug supply is remarkable. And therefore, and also lack of personal protective equipment. Over the first half year of this 2022, almost a quarter less TB were notified. Now you could argue less TB cases, but that's extremely unlikely because of the disruption in the lab services. You clearly have a lower TB notification, which is artificial, and that leads to lower drug treatment, scarcity of clinical trials, which are now mostly taken over for COVID testing, and obviously also deviation of funding. I'm clearly for funding and all this for COVID-19. I just think we have to see how we can expand funding so that the other diseases, be it TB, HIV, malaria, or neglected diseases, also need their funding. Because if this does not change rapidly, SARS-CoV-2 may kill more people indirectly through the neglect of TB, AIDS, malaria, and neglected diseases. More people will die of that than through COVID-19 directly. And I think therefore a rapid change is needed immediately for these issues. And with that, I thank you for your interest and attention.
Thank you very much, Stefan, for this really sort of impressive history of the vaccine development, but also pointing out the repercussion of the SARS virus pandemic. I should have pointed out maybe in the beginning to all the audience out there that there is a question and answer button at the bottom so that you can actually write up your questions if you have any, because I will then be able to see them. Currently, there are none. I just have a very, very short question for Stefan. If you could change anything in the development of a vaccine, if you could do something over again, what would you change to accelerate development? Or what was the possibly same question, same answers? What was the best choice that you made?
Well, for me, I would say there was a certain degree of serendipity, clearly, because I'm a researcher, a basic research at the Max Planck Institute, which is focused on basic research, really. So it took us much longer than if we would have done this the straightforward way. We started to understand biology, cell biology of BCG, of MTB, and therefore approached this from a basic research standpoint to stimulate CD4, CD8 T lymphocytes, more or less. And then we were in this lucky situation that indeed there was interest in developing this further into a vaccine, and that we came into contact with the largest vaccine producer in the world, the Serum Institute of India, who are the largest producer, by the way, because they produce vaccines and lowest possible cost. So this was a kind of a serendipity, I would say, but I wouldn't like to change it because I feel also happy enough at the surrounding that is focused on basic research. And I think it's extremely rewarding for me to work together with others who have their experience in vaccine development into the next stages in clinical trials. And I would actually recommend to some of those who are here in the audience that this is that sharing of the burden of the different aspects isn't a very important point. People should do what they can do best, and you should find those who can do best. At the same time, I think we were working hard to push forward vaccine development in general in the EU. I was amongst those who convinced the EU 15 years ago that there is something which we called at that time, we might change that word nowadays, poverty-related diseases, and indeed TB vaccine research was strongly supported through the EU 5, 6, 7 and then the Horizon 2020 programs. So there was clearly a strong support on vaccines. And if you look at the list of vaccine candidates, most of them indeed come through Europe rather than the US. Then they were partly taken over by others, but the origin comes from European funding. So that worked out also. Not
okay.
too bad, I would say.
Thank you, Stefan, for sharing this view with us. We'll now move on to the next speaker, who's Marilyn Addo. You may want to upload your presentation, Marilyn. She's from the University Clinic in Hamburg, and she's also a professor at another Leibniz Institute, namely the Bernhard Nocht Institute for Tropical Medicine in Hamburg. She's currently spearheading clinical trials for a coronavirus vaccine at the University Clinic in Hamburg. But I guess as an infectious disease expert, does not and will not neglect the so-called neglected but devastating emerging diseases. She was one of the pioneers in developing, testing, and implementing a vaccine against the Ebola virus. And Marilyn, what have you learned from this very successful project, and how can we benefit from your experience?
Well, thanks very much, Stefan, for this kind of invitation and kind introduction. I hope you can hear me okay, because I can't find my microphone anymore now.
Yes, we hear you very well.
Oh, beautiful. So it's really a pleasure for me to be part of this panel to discuss really important issues that arise even in the pandemic. And I agree with Stefan 100%. Even also if we think about the large, well, we have had many large Ebola outbreaks, but the West African Ebola outbreak, a lot of way more morbidity, or a lot more morbidity was caused through axillary or other diseases than actually Ebola itself. But the topic for the next 10 minutes is supposed to be the road to the first two Ebola vaccines, and I'm put a star there because obviously there are 4 licensed vaccines. There, one in China, one in Russia, and this refers more to the ones licensed in Europe. So it's a very interesting history, and obviously 10 minutes it almost doesn't give credit to this fascinating tale, because a lot of new initiatives had started in the aftermath of the Ebola crisis. So I will take you back a little to 2014, because you can ask, why did we not have a vaccine for a disease that was known since 1976? Obviously for TB, this has been much longer, but I also want to remind us of the history of Ebola outbreaks, because it's always fast to say, oh, we don't have a vaccine, it's not important. But if you look at the history over the years, it started here, the dark is the mortality and the light is the numbers. So there were parallel outbreaks in Africa in 76. And then there's a long period where there was nothing. So I guess it would have been very hard to make the case we really need to prioritize Ebola vaccine development in the 80s. And it was probably also in 2001 because of 9/11 and Ebola being placed on the bioterrorism list that we actually even have the candidates that went into early clinical trials, because I don't think many people foresaw that this would happen, really the most dramatic EBD outbreak in recorded history. And thankfully, we've not had a large outbreak like that since then, even though we've had dramatic and painful outbreaks in the aftermath. So at the time in 2014, there were really only 2 vaccines that had GMP material that you can actually use for clinical trials. Even though the non-human primate data had looked promising, a lot of them didn't really have, didn't advance into human clinical trials. And so it was really the ChAd vector and RVSV EBOV, and I'll talk about that a little bit later, that were ready to go right away in 2014. And then soon after, a lot more came. So I don't want you to go through the details, and because I'll give you a nice, very nice reference at the end to bring you up to speed. But out of this list, these 3 really made it to the finish line in the end, and I'll share some of the insights from the clinical development that we were involved in. This is a list that also Klaus Cicutek had in front of him, because he was part of the SAGE team that dealt with Ebola vaccines. So here you can see them again. RVSV EBOV is one, and the other one is a combination of viral vector vaccines at 26 ZBOV and the MVA-B and Philo. But I just want to, for completeness sake, also mention there are these 2 other licensed vaccines. It's the adenovirus that was licensed in China, Ad5, and the Gamivac Combi, which is a combination out of Ad5 prime boost and recombinant VSV. And as you can see, all of these are actually viral vector vaccines, and that has an implication also on what we see in COVID-19 disease vaccine development, because a lot of the players that were involved in this giant effort are also seen as major contributors to the vaccine field in COVID-19. So I think, well, if you can say that some good things came out of this dramatic West African outbreak, it certainly gave us a new viral vector that probably would have not gone into clinical trials as easily otherwise. So the recombinant VSV, this is actually moving without me doing something. So had not really been in clinical trials except for HIV, and really was introduced here at the time. It's like a negative strand RNA virus and has a simple genome structure, and really it wasn't really very hard for, like, no disease or asymptomatic or mild illness in humans. And so essentially the glycoprotein was switched from the wild type to express EBOF glycoprotein. And there were some drawbacks because it was really a new world virus, and you brought a new virus to humans. It was actively, or it is actively replicating and replication competent. And introducing that in GMO in Europe was not an easy feat. It had a lot of benefits, grew to high titers and replicated in the cytoplasm so that there was no integration. And since it wasn't a human virus, there was limited seroprevalence, and it really produced rapid and robust immune responses. And so a single injection was felt could be sufficient, which it turned out to be. And it was also able to use this as post-exposure prophylaxis. And in fact, this vector is now in clinical development for, well, had been for Zika, for Lassa and Nipah. And actually there's also a COVID-19 based vaccine that's going to clinical trials. Or it's probably already into clinical trials elsewhere, but it's going to clinical trials in Germany in the next year. So it was amazing to see the timelines on this clinical development, although we can probably discuss later. Obviously, up to this point, there was a lot of delay because phase 1 studies could have been performed outside of an outbreak scenario. But when the WHO declared public health emergency of international concern in August 2014, then in September, WHO convened a group of scientists. The WebCon consortium was formed. At that point, not a single piece of paper or a single protocol was written up or drawn up, but only 2 months later, and in the US actually a month later, clinical trials for phase 1 investigator-initiated trials were able to be initiated, 2 in Africa, in Kenya and in Gabon, and 2 in Europe, in Geneva and in fact in Hamburg. So this trial showed the vaccine to be safe and immunogenic and had 100% seroconversion in all dose groups across the different countries. It showed good binding antibodies, but also excellent virus neutralization titers. And it was really the preliminary data from this study informed the dose finding for what it was going to be the landmark study. And actually, this is the dose that's actually licensed at this point in time as well. So dose finding for which study? A ring vaccination trial in Guinea at the time. The ring vaccination strategy had been known for a long time from pox virus eradication efforts. And so a ring is really the geographical setting where a newly diagnosed case of EBD lives, and then you vaccinate around this case. And what this study, the Ebola Sasufi trial, could show was really that in the rings where immediate vaccinations were implemented, there were no infections, and in the ones that used 1 incubation period and were implementing delayed vaccinations, there were 16 infections. And this is really a lot of the data, or like some data that then was used for the licensing as well. So the strategy, even when the vaccine was still in the licensing process, was then used successfully in ring vaccination protocols in the subsequent Ebola outbreaks. So there was one in the Région Équateur in the Democratic Republic of Congo in 2018. Then in 2018, later that year, there was the large and long outbreak in the Kivu. And they were able in this outbreak actually to vaccinate like a six-digit number of individuals, and were able to even perform studies like in an outbreak scenario and in that region, which is really has to be commended. And they could demonstrate that there was 97.5% efficacy, even in this like real world setting. This data was released in April of 2019 on the WHO website, and I have yet to find the publication to that, but you can easily find it on the WHO website. So this figure is taken from a review that I will like show you later because I think it's a great reference, but shows you human clinical trials for Ebola vaccines. I'm only discussing the two of them right now a little bit more detail. And as you can see up here in A, these are the people and study participants that have been vaccinated with VSV Ebola in the licensing process, plus the ring vaccination protocols in the outbreaks. This is a paper from 2019. So these are the numbers that have been vaccinated. So, and all of this then led in 2019 in November to the first licensed Ebola vaccine in Europe, and then the FDA followed suit. Ervebo is the name and was approved as the first Ebola vaccine. So just to kind of like, as the time is a little short, I will then move on to the second vaccine briefly, since I wasn't quite as intrinsically involved in this clinical development, but it's really also astounding because all of the data that was generated for this vaccine also came from outbreak scenarios. And there's a paper in Global Health Action that is going to only appear in December 31, so it felt like a glimpse into the future that I would like to refer you to for more detail of how to implement such research and accelerated research in an outbreak scenario under these conditions. In any case, as you can see, like an excerpt from the same figure that I showed you before here, the AD26 EBOV and MVA had about like 5,000 a little over 5,000 individuals that participated in the studies. And this vaccine is also a viral vector vaccine based on two components that are developed by Janssen or Johnson & Johnson. It's the first component is the adenovirus 26, which is not quite as prevalent in the human population as AD5. AD5 obviously has some drawbacks, and there has been a history in HIV vaccine development with a dose that is shown here. And then the second component is the MVA BN philo, and I think that's quite interesting because this is the dose 0.7 times 10 to the 8th infectious units. This philo actually, in contrast to all the other Ebola vaccines, has different Ebola strains. As you can see, Mayinga, the Gulo variant from Sudan Ebola virus, then the nuclear protein of Thai forest, and then also a GP of Marburg virus included. So this is actually a very interesting vaccine, and was, oops, no, that, sorry, I apologize. And so these vaccines were licensed this year in July, and this is really something that probably would have gotten a lot of more attention if it hadn't occurred in the middle of the COVID-19 pandemic. So these vaccines are now called Sabdino and Mvabea, and like it's a prime boost strategy where the first vaccine is the adenovirus and the second is the MVA, and it's about 56 days interval that it's applied. And as I mentioned before, the AD26 vector is also now in clinical development and in clinical phase 2-3 trials for COVID-19 as well as is MVA. So with that, would like to summarize that really the West African Ebola epidemic in 2014, 2013, to 16, led to accelerate vaccine development initiatives really conducted at unprecedented speed. And I didn't put those timelines up for time issues, but this effort really led to the first 2 vaccines receiving conditional marketing authorization in Europe. Ebola also through the FDA, but I guess for the other product, those discussions are still ongoing. Russia and China, as I mentioned, also have approved vaccine products that is also similar to the situation that is displayed in COVID-19. So when there was the outrage on Sputnik, you know, this is not without precedence in Russia. And really at this point for Ebola, our currently licensed vaccines are viral vector vaccines, and those also play an important role in the COVID-19 vaccine development, as Klaus Tichutek will probably also point out later on. And I guess the lessons that we've learned from the rapid Ebola vaccine development have really also informed the current vaccine development for in the topic of SARS-CoV-2 vaccines. And when we thought we were fast in 2014, we also saw how these timelines can yet be accelerated, and that just the mere fact that from the detection of a new disease and a pathogen in December and January of 2020 to starting the first clinical trial 3 months later with a participant rolling up the sleeve clearly has not been seen prior to this. Let's see. I always have to move your faces around, so but I wanted to mention another thing, that important initiatives and structures have been already mentioned by Stefan as well, have been created in the aftermath of the West African Ebola epidemic. For instance, institutions like CEPI, the Coalition for Epidemic Preparedness Initiative, really came to play afterwards. There was the expert panel that made the blueprint list, because we saw during the Ebola pandemic that we didn't have diagnostics, no vaccines, and no therapies, and like we always run behind pandemics, and I think this was a great wake-up call to move forward and actually have proactive initiatives, proactive funding mechanisms to make us better prepared. And I guess we still don't have a COVID vaccine, but I think we reaped some benefits from this development. So, and with that, I am actually just wanted to share with you this excellent review about Ebola vaccine development, which is quite recent, from 2019, and obviously written by experts in the field, Andrea Mazzi and Heinz Feldman, and really summarizes with clinical trials numbers a lot of the amazing effort that went into Ebola vaccine development. And so with that, I thank you for your attention, and I'm happy to take questions. Thanks.
Thank you, Marilyn, for this rather in-depth view of the development of the vaccines. Nobody seems to write down any questions from the audience, so I feel forced to ask questions myself. But we can since we're advancing in time, I think we should leave those questions to the very end, so each and every one of you can have more of a final statement on the overall implications and ramifications that this has for vaccine development. So we'll come to the next speaker, Klaus Tichutek. Klaus, can you please start your presentation? Klaus Tichutek is the scientific director of the Paul-Ehrlich Institute, Germany's major regulatory body for registering and licensing novel diagnostics and therapeutics, among them vaccines, of course. He is obviously currently a man very much in demand. And Klaus, I'm glad you found time to enlighten us as to what you believe are the strengths and pitfalls in vaccine development and acceleration of vaccine development right now.
Thank you very much, Stefan and colleagues. I hope I can be heard well and you see my presentation.
Yes,
I want to go quickly through it as we have very little time. Basically, we learned a lot of regulatory lessons for the future development of preventive vaccines. And this comes from the experience with Ebola vaccines and also the COVID-19 vaccine development that's ongoing. And I want to briefly inform you about the basic conclusions from that. Number one, I think it is very important to identify a protective antigen of the virus class. And that is a very important prerequisite for vaccine development. And that seems to be rather trivial if you look at small viruses, and we very often have the case that the outer membrane or envelope proteins are the immunodominant antigen that may confer protection. But in many cases, it's more complicated, and the viruses have a whole array of different proteins. And as you know, in bacteria, it's even the polysaccharides which provide the epitopes for protection. In order to do so, of course, we need the vaccine platforms, and Marilyn has already told you that there is quite a bit of new developments. So we have, of course, the established ones like the inactivated whole virus vaccines, the live attenuated ones, the protein-based subunit split recombinant protein vaccines, and in a way, the new kids on the block are the DNA, RNA replicating vector, non-replicating vector vaccines. I'm very often asked which ones are the preferred ones. There is no preference because all vaccine products have different characteristics, and the characteristics not necessarily stem from the vaccine platform that has been used. But as you may know, some of the new vaccine platforms allow rapid generation of new vaccine constructs, and that may of course be a plus with a view to new pathogens arising. Now, the protective potential of an antigen needs, of course, to be defined on the basis of animal challenge studies. But the issue of this is not always are non-human primates the animal model of change, and you need to find a suitable animal model. And that's very important for us, not only to study the immune mechanism potentially conferring protection. It's also very important in terms of toxicity of the vaccines, local reactogenicity testing and other things. And one thing that is very often overlooked is the fact that you need really good standardized assays and a reference material that has to be developed to measure humoral and cellular immune responses. And I was just sitting for a whole week in a committee that looks into that, and I think it's considered rather boring, but it's very important in order to compare between different laboratories, the measurements that are done, and of course, very often neutralizing antibodies are the important ways of protecting against infectious disease. Now, we have learned particularly and have applied in the COVID vaccine development that there are some studies that have to be done preclinical. These are the red ones, and the yellow ones are the ones that can be postponed and be done parallel to clinical trials. And that's a new way of thinking we haven't done before. There's first of all the primary pharmacodynamics, which is the immunogenicity studies in animals that have to be done prior to first in human use, the safety pharmacology to look at toxicity issues generally, and the local tolerance, which is very often assessed and repeat dose toxicity studies, but can also be done in the safety pharmacology. And then other things have been postponed. We've provided a lot of scientific advice. This is biodistribution toxicity, reproductive toxicity, and protection in suitable animal models. So that's a new way of thinking with the experience we have. Very important is in phase 1 or combined phases, immunogenicity and dosing has to be studied. General safety, tolerability, reactogenicity, systemic events are a very important issue because we don't want the grade, severe grade and grade 4 events happening with administration of a vaccine. And another important lesson learned is also that there are some risks you can think of, so-called theoretical risks, and it's good to address them in animal studies, but later on also in the clinical trials. Now, I've given you here the pictures you've seen from recent publications, the traditional development defining the protective antigen, manufacturing, preclinical tox studies, phase 1 to 3 trials, then submission of marketing authorization application to FDA or European Medicines Agency, where we assess them from the side of Paul Ehrlich Institute, then later large-scale production. And you see here, this is compressed now in the COVID vaccine development by doing some clinical studies before, others parallel to clinical trials by using adaptive clinical trial design, and by starting production manufacture of a lot of doses of the best vaccine candidates. And that's written down here. And I think it's important also to look into the fact that phase 3 trials have to be done with at least 3,000 subjects and more. And of course, it's of an advantage that you have efficacy clinical trials in epidemic regions with high infection rates, but there's something that the FDA calls animal rule, called a bit different in Europe, where we can also confer by comparison of immune parameters protective efficacy from other vaccine examples without studying the vaccines in epidemic regions. I want to sum up and sit tight because I'm going to run through a lot of different demands. First of all, I've told you identifying the potentially protective antigen beforehand for, let's say, the virus group would be important. We learned from previous vaccine developments that progress to clinical trials, and that speeds up development of vaccines against new and newly emerging pathogens. New technologies allow rapid generation of new vaccine constructs. That is definitely a plus that we may have also in COVID vaccine development. If there would ever be a strain arising that is not completely covered in terms of protection by the current antigen choice, we can rapidly generate new constructs. The genetic vaccines have the advantage of being able to be used in the manufacture of millions of vaccine doses in very short time periods, for example, 6 weeks. There are currently stability issues with RNA vaccines, storage at -80, which have to be solved by improving formulations. The clinical experience, as Marilyn told you, with the Ebola vaccines with replicating, non-replicating vectors, I think may pave the way for rapid development. Similar vaccines for other pathogens. The efficacy phase 3 trials have been affected by epidemics and pandemics, but they should rapidly progress. That's what we learned, and it's important to allow more than 3,000 subjects to be enrolled. Some non-clinical studies for vaccine licensing are performed prior to first in man, others parallel. We use adaptive trialing to combine clinical trials. And the issue is that vaccine development is still rather empirical. I think we have to look also into the immunology and the science of vaccine development and look for good markers for immunogenicity, reactogenicity, systemic reactions, and of course efficacy, and they will be very useful for the progression of vaccine developments. This is what I would like to tell you as lessons learned from the side of Paul Ehrlich Institute, and I think we have learned that frequent scientific advice by us and other medicines agencies is really a plus, particularly also for academic researchers that want to do vaccine development, because it helps to avoid unnecessary, let's say, preclinical studies, but to concentrate and focus on the very important ones. And we're always here to help you. And we have seen a lot of vaccine development from all over the world. And I can tell you that in the vaccine development that we currently have, we have the plus that there's a lot of synergy between academic labs that support each other in research. There is a lot of developments and synergies being sought by forming consortia. The CEPI has been very important, the funding of the government in Germany and the European Commission. And I'm looking forward to having hopefully good vaccine products also against COVID on the market by next year. And with that, I would like to end and thank you for your attention. Bye.
Thank you very much, Klaus, and also for staying in time. Thank you. We have one question actually from the audience, which addresses this issue that you spoke about in the very at the very end, from Andreas Holzhofer. He asks that there are currently plenty of developments ongoing for COVID-19 in the vaccine department, but how can you actually find the most effective one fast? How can that one be identified? And many countries have ordered several manufacturers. How would you design a challenge trial, possibly by intentional infection? And could this be justified ethically? Maybe Klaus, you could start by answering that.
Yeah, number one, the most effective ones we will see through the phase 3 trials. And there's nothing that can make us foresee what will be the ones that are good. I'm often asked what are the best ones, and I think we just have to await the results, and the current runners-up are the ones in phase 3 trials. Number two, yes, countries have ordered vaccines, or let's say have made advanced purchase agreements from several manufacturers. I think that's a good idea because different vaccine products will have different characteristics. They may be used under certain conditions, and it's good to have a whole array of them, and there's no way to foresee which ones will be good for certain situations. But I can assure you that all the ones that we will have licensed will have a good benefit risk ratio. The question here arises, what is efficacy of a COVID vaccine? Many of the current developers look into avoiding severe causes of disease or COVID symptoms altogether. What we do not know is whether these vaccines will also prevent transmission. And that's what we're going to see. That's an important aspect. And now somebody took away the question. I don't know whether I answered
I'm sorry,
all of them.
I actually did this because I just wanted to say it's being answered right now. I think one of the issues was whether it can be ethically justified to intentionally infect or challenge people with the virus.
I think for my mind, that's not really necessary and cannot be justified because we don't have therapeutics that are very effective. In the situation of COVID, it would put subjects in danger, and we currently have the situation that there are plenty of regions in the world where good efficacy data can be found in phase 3 trials, so I don't see the need.
Marilyn, can I ask you as a follow-up to this? You've experienced the development of the Ebola vaccine. Are both the ones that you know, or the other two, are they equally effective? In the end, could it be that we have 10 very effective vaccines for COVID as well?
Well, so we don't really know. The second vaccine was licensed on the animal rule, and I think that Klaus had this on his slide. And the first vaccine had actually shown 97.5% efficacy. So we don't know, but it's not unusual to have several vaccines. And I think in the context of COVID, I think we will probably need several vaccines. Number one, because not only one producer will be able to supply the entire world. We don't know which one is going to be the runner-up. We clearly don't need 200, but it's probably foreseeable that we will have like maybe 4 or 5 products that will go. And then there have been other discussions about those runners up now, like 2 RNA vaccines and the vector vaccine are like the furthest advanced, but they're likely going to be either post-pandemic or like the second generation vaccines that will be emerging. So I think there are a lot of open questions as to which vaccine is going to be appropriate for which population. Like we haven't really talked about children at all, risk groups, etc. There are lots of questions that need to be answered.
Stefan, if I may add just to this conversation that we see from the current clinical trial holds, which were done by the sponsors, that unforeseeable events can occur. I am in the position to say that I don't have the feeling that the current holds really are done because there are adverse reactions attributed to the vaccines. But of course, we have to look into any event. It's a good sign that events lead to clinical trial hold, but it just shows that there are unforeseeable events during the development, and therefore it's good to look at all different platforms and have several products being developed.
Mm-hmm. Okay, thanks very much. I think we'll move on at this point to Stephen Sinkins. Stephen, can you upload your presentation, please? Stephen Sinkins is head of the Institute of Infection, Immunity and Inflammation in Glasgow, in Scotland. He's one of the pioneers, actually, of blocking transmission of arboviruses by infected mosquitoes. He's conducting collaborative open field trials in Malaysia, among others. And with his talk, we're now moving into the benefits, into the area of the benefits and problems of implementing science in the field. Can you share your screen with us?
You don't see that?
No? It's coming up now.
Great. Okay.
Okay,
Thank
there
you
we
very
are.
much.
Okay.
Okay, thank you very much for the opportunity to share this work with you. It's a collaboration, as you mentioned, with a group at the Institute of Medical Research in Malaysia, led by Dr. Nazni and Ari Hoffman at the University of Melbourne and his team, together with us in Glasgow. So a quick introduction to dengue. It's become over the last 50 years very much the biggest of the mosquito-borne transmitted viruses, in the range of 80 to 100 million cases, clinically apparent cases every year now. It has 4 serotypes, which makes its immunology very complex. It's one of the risk factors, secondary infection with a different serotype for developing severe dengue with hemorrhagic fever and shock syndrome, leading to around 40,000 deaths every year. So right across the tropics, the distribution of these 4 serotypes has been increasing and co-circulating, including increasingly in Africa. The primary vector mosquito is Aedes aegypti, which is an urban mosquito, which is very well adapted to living in and around and biting humans. Day-biting mosquitoes, very difficult to control. We can't use bed nets as they're day-biting. So it's vector control is very much still a mainstay of dengue control, but because it's so difficult to control this species, this primary vector, it's really about containment rather than reducing the incidence of dengue on a global scale at the moment. So it's depending on larval site removal, tires and rubbish that can accumulate water, insecticide fogging, but that only gives a temporary knockdown, and there's increasingly insecticide resistance. So the system that we've been trialing is a bacterial symbiont found in many insects, very common and widespread, called Wolbachia, but it's not naturally found in Aedes aegypti. But it can be introduced. The way that we have to do that is with embryo microinjection. We've introduced a number of different Wolbachia strains. The one that we've taken to the field is from Aedes albopictus, another mosquito. And we find that when it's introduced into Aedes aegypti, it reaches high density, and crucially, it can block the transmission of dengue and various other viruses that Aedes aegypti transmits. The other important characteristic of this symbiont Wolbachia is its ability to spread through populations of its host insect, in this case, the Aedes aegypti mosquitoes. When the males carry Wolbachia and the female does not, the embryos don't hatch. It's so-called cytoplasmic compatibility, and it gives a reproductive advantage to females that carry Wolbachia because very high rates of maternal transmission occur. So it's only transmitted from female to the offspring and not environmentally. So those 2 combinations of characteristics, its ability to block transmission and a self-spreading capacity, have led to these trials to take it to the field. So it's dependent, because of this solely inherited lifestyle, to get it out into the field, to deploy it, we have to actually release mosquitoes. And the way that we're deploying it requires release of female mosquitoes, biting mosquitoes, as well as just males, because the end point is to get Wolbachia to a high frequency and to block dengue transmission. So obviously, community engagement is really important, because you're going to be releasing mosquitoes, biting mosquitoes, albeit in quite small numbers. And this was done in the selected sites in Kuala Lumpur through meetings, through door-to-door engagement. But there was a lot of enthusiasm, actually, because these are the selected sites at dengue hotspots. And it's been very difficult to bring dengue under control in those sites. So we can do releases with adult mosquitoes. Here you've got a tray with around 50 mosquitoes per cup, which are released. A cup is released every 3rd house once a week, or you can release containers where the eggs are added and they develop on site. So this is an example of one of the sites that we targeted, a dengue hot called Mentari Court, Kuala Lumpur, which is the 17 complex of buildings where dengue transmission has been high year on year for a long time. Here you can see the releases of Wolbachia shown in gray over a period of weeks, weekly releases, and the frequency in blue goes up quickly. And then crucially, it stays high because of the cytoplasmic incompatibility mechanism. So it's still in the high 90% frequency. So that's exactly what we want to see. It's very important for it to be stable when introduced. And looking at dengue, again, using this Mentari Court example at the top here, dengue incidence over the years since 2013 goes up and down a little, but after the start of the Wolbachia implementation shown in blue, you can see that cases go down considerably. So we're looking at between our 8 sites in the first phase, between 60 and 90% reduction in incidence, and against a background in the control sites, which are matched on building types, where you've still got these peaks of dengue happening. So it is working. It's working effectively in this case, and crucially, once you've done this period of release, it's staying there at high frequency in that population. So it can be very cost effective. That's a really attractive feature of this system, that it's stable once it's been introduced. And you no longer need this case responsive insecticide fogging, which many governments, including Malaysia, spend a lot of money on and have big personnel teams. So those resources can be diverted for the wider rollout into Wolbachia programs, which is happening now in Malaysia. They're in an operational phase. They've already been carrying out releases in 17 further sites with a lot of success, all of which are dengue hotspots. So it's covering around 100,000 residents in those further sites now. And once COVID situation improves, we hope further rollouts. But it's already in Selangor province, as well as Kuala Lumpur and Penang. So it's looking very good. One of the questions that we need to address now is, in terms of longer term monitoring, is will this virus blocking, transmission blocking phenotype, can we maintain it in the long term, or will it be lost? And there are several ways in which that could happen, the most important of which are potentially the selection of viral escape mutations. We don't have any evidence of that happening as yet. One thing that's encouraging is that there are multiple perturbations by Wolbachia inside the mosquito cells, which influence viral replication, from lipid metabolism transport to endoplasmic reticulum stress, which is the virus which dengue depends on for setting up replication complexes, and Wolbachia suppresses autophagy as well, which again dengue depends on. So because there are multiple perturbations and mechanisms, that makes the selection of escape mutations less likely. But one cause for concern is that under high temperature conditions, a different Wolbachia strain called WMEL, when it's raised as larvae under high temperature conditions with a peak in this example of 36 degrees, which certainly is in the range that we've seen experience in Kuala Lumpur, you see a loss of this phenotype and you see a reduction in density. Whereas the strain that we're using, and that was the reason that we chose that strain, WLB, is stable under those high temperature conditions. But WMEL is being released in other countries, and that is a concern that under these suboptimal low densities, that might increase the risk of viral escape mutations. And then the other main possibility of how over the long term we might lose this virus blocking phenotype, we might lose efficacy of the intervention, is if we have selection for low Wolbachia density. But again, we've been monitoring that. We have years worth of data now from different locations. We don't see any evidence of that so far. I think that's going to be the long-term trend, but certainly within the time frame of this intervention, we're not seeing that happening so far. We're seeing maintenance of high densities and maintenance of transmission blocking. So far, so good. The challenges associated with the COVID pandemic, of course, have delayed the wider rollout, but we're hoping to resume at full speed and take it to other countries in the near future. Thank you.
Thank you very much, Stephen. May I ask you one, just as out of personal interest in moving this further out into the field, what in your opinion was the single sort of most important factor to that has determined success in Malaysia? Is there anything that you can give us as a piece of advice if we do field research the way you do, what makes it more successful?
I think it was really important in terms of the field programs to have local leadership, local ownership, and local leadership. We produced the lines of mosquitoes, and we provided a lot of advice along the way, but it's really the local expertise at IMR, long experience of control of vector-borne diseases, including dengue, and their interactions with communities that was really, really critical for success. So I think in terms of long-term success of being able to feed directly into a rollout with the Ministry of Health as well for sustainability and long-term success, it's extremely important to have that local leadership and capacity building in a program like this.
Thank you very much. I can see there are more questions coming in that address issues mostly to do with vaccines and vaccines against viruses. Actually, there's just come in one question from Gish, which I shall read out to you, or can you read it on your screen as well? I'll read it out loud. A person who's not from the field of parasitology particularly, she just thought that Wolbachia is also an endosymbiont in filarial nematodes, and many countries would be endemic for both dengue and filariasis. Do you think introducing Wolbachia, for example, might somehow influence the spread of these other diseases like filariasis?
It could be used for filariasis control, certainly. It's important to say that the Wolbachia that are found in filarial nematodes are different clades of Wolbachia, so there's not a direct interaction. But this kind of intervention with mosquito Wolbachia, introduction of mosquito Wolbachia, could be used for filariasis control. Of course, you've got the mass drug administration programs, but there are cases where filariasis control has been very difficult. There's a vector called Aedes poliniensis in the South Pacific, for example, where introduction of Wolbachia could be an attractive way for interrupting that transmission, which becomes more efficient at low filarial densities. So yes, there are applications for filariasis as well.
Okay, thank you very much. The virus questions we'll keep to the end and have other people address that, because we'll have our final speaker, John Amuasi, now please upload his presentation. He's at the Kumasi Center for Collaborative Research in Tropical Medicine in Ghana. He's also the co-chair on the Lancet Commission for One Health. His admonition is that developing programs is one thing, but implementing and finishing them is really key, because particularly where malaria control is concerned in Africa. So John, there you are, confronting the elephant in the room. John, you need to turn on your microphone.
Yeah, should be okay now. Can you confirm that you can hear me?
Yes, we can hear you very well. Can you turn on the presentation mode, because it's still not, yes, this is fine.
Wonderful. No, so thank you very much for having me. I'm cognizant of the time, so I'll try to run through to the best that I can. And as you can see from the slide, the topic I've chosen is confronting the elephant in the room, why malaria control remains critical to Africa's future. I'll just run you through a couple of slides just to review what we know about malaria. These are things that many of us panelists and also in the room, I see we have upwards about 41 people following right now would know. But this is a slide that just speaks to historically the interest that has been present for malaria control, which has gone beyond simply human health to focus more on the economic interests. Of course, you can see here the cotton industry, the sugar industry, and this is from years back. Moving forward, the current burden of malaria in Africa is still huge. We're speaking about 213 million cases in 2018, accounting for about 94% of all malaria deaths worldwide, that is Africa. So some people complain as to why there seems to be so much focus on malaria in Africa, but the truth of the matter is that the greatest burden for this disease is on the continent. And the interesting thing here is that it's about 6 countries that are accounting for more than half of all the cases that we have on the continent. And 1 country, which is Nigeria, accounting for almost a quarter of all the cases in the world. So a little more on this. The interesting thing about malaria is it seems to be a programmed killer that addresses people who are most vulnerable. And what a worse way to attack the human population than to attack right at the point where there is reproduction, or where there is the increase in the population, which is pregnant women and children. And so malaria seems to be attacking most efficiently in this space. And it seems to insert itself at a point where it leads to a vicious cycle of poverty, because you will end up with children who are anemic, children who are therefore unable to perform well in school, children who are therefore unable to break out of the cycle of poverty. And then it goes on, because if they are poor, then they are more likely to be even more susceptible to malaria because of their living conditions. So it is really what we call a programmed killer that requires an integrated approach towards addressing. This is perhaps the most up-to-date map of the malaria burden globally by country. And you can see the different colors that tell you where the concentrations are. Now, I always tend to take these maps with a pinch of salt, because they are often a reflection of the quality of reporting that may be present in a country, especially when you're thinking about sub-Saharan Africa, because there are many countries for which reporting is very minimal, or reporting may not be entirely representative of the entire country. So, well, this is the best that we have, and we can only work with the figures that we have available. It's not all doom and gloom, because there's been significant progress over the past decade, with about a 22% reduction in the incidence level of malaria in Africa, and more countries being certified as free from malaria, including Algeria most recently. And also the greatest levels of reduction globally have actually been in Africa. The good news, and this may fall certainly more within the range of Maryland and others' workspace, the malaria vaccine is being tried in Ghana, Kenya, and in Malawi. Even in my center here at the KCCR at the Kwame Nkrumah University of Science and Technology campus, I know the PI for the malaria vaccine trial is right here. So my question is, are we becoming victims of our own success? And I say this because malaria control strategies in sub-Saharan Africa have relied very heavily, especially the preventive part, on certain interventions that are targeting the mosquitoes, especially since the early 2000s. You may have heard a lot about insecticide-treated nets and indoor residual spraying, and this agenda has been pushed very strongly over the past 2 decades. And it has not been without success, and rightly so, because they've contributed about 68 and 10% respectively. That is, insecticide-treated nets have contributed about 68%, and the IRS about 10% decrease in malaria cases. So the vector control strategies have worked. And they worked so well that it led the WHO to revise their global targets for reducing burden of malaria by 2030. Now, why do I ask, are we becoming victims of our own success? I'll take you back a little bit into some of the history behind vector control. And right from South America through into Africa in the 1960s, there was a massive push towards eradication of malaria, with the main thrust being vector control. Of course, we now know today that vector control alone is not enough. We need to look at the therapeutics and need to look at the prevention parts of it. These are what we call them the malaria capers, also mercenaries, just with their gear going through the jungle as part of vector control efforts. Now, we've had resurgences and re-emergence of malaria on account of failure of surveillance. to be able to recognize and respond on time, and inability to detect outbreaks. Of course, we're getting much better at it these days with the Sentinel sites that exist in many countries, being able to measure the incidence rate of malaria and be able to step in. But in the early 90s, there were literally epidemics of malaria in many African countries that either went undetected or went unattended and led to the death of several thousands of people. One thing I want to speak to specifically, which has been a phenomenon since the 1970s and continues even more strongly today, has been the issue of mining, the small-scale mining in forest areas in Africa, which have led to a resurgence in malaria. And you see all these pits, shallow pits that are dug, which not only destroy the ecosystem and the terrain, but also are fertile breeding grounds for the Anopheles mosquito. So the reason why I say we may be victims of our own success is that the mosquito appears to be adapting to the indoor fight. We are focused a lot on the insecticide-treated nets and the indoor residual spraying, but it looks, there is ample evidence that the mosquito has evolved fairly rapidly and is becoming resistant to the insecticide-treated nets or the chemicals used in the insecticide-treated nets, particularly the pyrethroid, as well as the chemicals that are used for the indoor residual spraying. And it's become a catch-22 situation because the resistant Anopheles phenotypes may be more susceptible to the Plasmodium falciparum infection, which again would link it with the escalation of the pesticide-based indoor intervention. So in a way, our interventions are actually allowing the mosquitoes that are more susceptible to Plasmodium to flourish. So it's a bit of an odd situation. And this schematic that I took from this beautiful paper by Sugufara, which was very recently published, really speaks to this issue, which looks at the selective pressure associated with indoor chemical vector control interventions, which are beginning to affect many of the characteristics, the biological characteristics of mosquito populations and the traits that affect the vectorial capacity and transmission. So the physiology, the population genetics, and then the behavior of these mosquitoes is all changing in favor of the mosquitoes that will not be found inside of the rooms, which means that we need to think differently about how we're doing our vector control. So I have captioned the current move as taking the fight outside, and very literally it is taking the fight outside, because so far we've been fighting inside with the insecticide-treated nets and with the residual spraying. So this is a paper again, an illustration again from Sugufara et al., which just shows the focus that there has been on the insecticide-treated nets and the indoor residual spraying over the years. And you realize that there's hardly been any attention, if you look on the bars on the right, the red bars, any attention at all given to the outdoor or exophily and biting behavior in Anopheles in Africa. And it's very interesting that we see the skewness. The mosquitoes, as I said, are adapting, and if you look at the tools that we currently have for vector control, hardly any for outdoors. Basically just two WHO approved tools, which are the larval source management and space spraying. And even these two have serious limitations, especially in rural areas, and I'll speak to this. The mosquitoes are changing their behavior by biting earlier at dusk. They're feeding more often on non-human hosts. They're resting outdoors, especially to avoid the vectors. So these are the challenges that we're facing now in the current vector control research arena. And if you look at each of the malaria vector control activities, from long-lasting insecticide-treated nets through to indoor residual spraying, the larvicides, our knowledge and monitoring programs, you see how there are so many mitigating factors that need to be addressed, and even questions as to whether some of the activities that we are engaging in are actually reducing malaria incidence or not. They may reduce the deaths from malaria, but are they really reducing the incidence of malaria, which itself has implications for health outcomes, especially long-term health outcomes, and implications also for breaking the cycle of poverty. I'll not spend too much time on this because I see that the time is running short on us. So I'll go on and speak to some of the research that we need, including implementation research, to improve the quality and the delivery of mosquito vector control. We should focus on the optimization of processes and methods for vector control delivery, especially the monitoring of the vector populations and the biting activity in order to really understand where they are, how they are behaving. And again, I showed you the image which tells us how few the tools that are currently approved for fighting the vectors outside are. We also need to carefully evaluate the sustainability and the suitability of some of the new tools, because some of them actually may cause more harm than good, depending on whether people are in rural or urban areas, and even in different kinds of geographic locations. Need continuous monitoring for environmental changes. There may be some environmental impact of our activities to control the vector. And also there are natural environmental changes which the mosquitoes adapt to, which we need to follow. Otherwise, we might be fighting a new war with old equipment, and that just won't cut it. Certainly the need for cooperation among many disciplines, right from the basic scientists through to the ecologists, entomologists, and so on. I don't want to spend too much time on this slide because this speaks to the current changes that we are facing when it comes to malaria in Africa. Most of these you are aware of, but it's just to show you that we are far from out of the woods. There has been significant success, but still so much more that needs to be done. I'll focus perhaps on the last bullet right now, which speaks to the funding gaps that we have. And just as recently as 2018, we fell short by almost 50% of the funding that was needed to appropriately address malaria in Africa. This is not to eradicate malaria, but just to keep the control going. And we're already 50% short. With the COVID-19 coming up in 2020, definitely going to have a severe impact on our malaria control activities. And everyone is looking with bated breath for the figures that will come out for malaria moving forward post the COVID era. Already we're seeing its impact on the economy, and by all means, it's going to have an impact on other diseases, including malaria. And I'll move to my last slide, which is the high burden, high impact strategy, which is the strategy which has been recommended by WHO to get countries back on target to meet the 2025 Global Technical Strategy for Malaria milestones. And this focused largely on political will, the strategic information that will come through research, and the better guidance that will come out of that, as well as a coordinated response. And I made mention of this, the need for interdisciplinary and transdisciplinary activities. Of course, all these are on the platform of an effective health system, because without the health system to move this, all these efforts will definitely just fall to the ground and collapse. And with that, I would like to say thank you very much for listening to me, and I'll be happy to take any questions.
Thank you, John, for this rather actually ecological view and interdisciplinary view, and of little addressed issues in malaria control. We have only 10 minutes left, and I think we should all be given, you should all be given a chance to just say 1 or 2 minutes of a final statement addressing some of the questions that the audience has had. One of the questions is about fears concerning the vaccine. Whether anybody of you in the panel might want to answer that question. And also the question as to how low-income countries in Asia or Africa are going to have fair access to the vaccine, and whether they're also involved in the development in regard to different type of vaccine. I guess this concerns all vaccines, from Ebola to tuberculosis to COVID-19. And one final question, maybe John, you can try and start with that. Are there any ideas to develop a vaccine against malaria, and what's the current status? Only 1 minute, please. It's going to be a difficult one.
Yeah, no, I'll try and be quick about it. Thank you very much. Yeah, so with regard to the vaccine, as I mentioned, the malaria vaccine is in its final trial stages in a number of countries, including Ghana and Kenya and Malawi. There's been a lot of discussion around the effectiveness of the vaccine, and a lot of politicking around it. But by and large, it's been shown to be fairly effective and should be able to make a difference, especially when you do focus this on the risk of malaria in children and its impact ultimately on their health outcomes and the probability of them breaking out of the cycle of poverty. Again, the issues around the stigma and the negative press and the misinformation around vaccines is always ever present. And this is why there's a need for continuous engagement with the private sector, with communities, with grassroots organizations in order to make sure that the information is clear right from the outside. And we're already doing this here in Ghana, even with some of our COVID-19 clinical trials, not for vaccines, but for the drugs. We're just waiting also for the vaccine trials to come along with their own challenges. Over.
Marilyn, do you want to say something about involvement of the population in Africa towards vaccine development and actually a fair distribution of vaccines among them?
Well, yeah, so these are very critical points. And like, I'm assuming you're referring to the COVID vaccines that are in development. So in general, I would say there are programs that also will have programs that conduct trials in Africa. So they are like also part of the development path. But then more importantly is access. And there have been instances in other vaccines where access has not been equal in the world. And the efforts that I see now, like even like early on, months ago, even when we were even further away from a vaccine that's going to be licensed, this has been brought to political attention on the EU level, at least in words. So like we have to see if action will follow, and COVAX and other kind of initiatives will try to make sure that a vaccine or vaccines developed against SARS-CoV-2 infection will actually be distributed in the world in a fair and equal manner. I guess the question on fears about vaccines should probably go to the regulator.
Yeah, I was going to ask Klaus about that, the safety and concerns about the concerns about the vaccine.
Yeah, I think most of the people in the world wait desperately for a vaccine because they want to lead a normal social and economic life from now on. In terms of safety, we'll have a database for each product on the safety of the vaccines being administered to something like 20 to 30,000 people. And the follow-up will be a couple of months, at least 2 or 3 months for some of them. I think that's a fairly good safety database. But of course, very minor, extremely rare events could always occur. That's usual with the introduction of new vaccines. But I think in general, we can be confident that the vaccines will be good and they can be used officially. Let me briefly answer to the other question also. I think our government as well as the Commission have stated that they will follow the COVAX, but they will not purchase the vaccines through the COVAX. They will follow other routes, but they have are considering the COVID vaccine products as global goods. And I think there will be doses that will also be used somewhere else outside of Europe, plenty of them. Because the pandemic is overall, we have to distribute the vaccines to everybody. Over.
Okay, Stefan, maybe you would like to comment on also common avenues maybe in vaccine development. It seems that there's always got to be one thing specific for each particular bug and disease, but there are also common avenues there.
Well, I would like, if you don't mind, shortly comment also what has been said. I think it has been clear for decades, if not from the beginning on, that vaccines benefit people much more and that than for the private companies. So I think like Gavi had made it already clear that we need advanced market commitments, we need dual price systems. And that is now kind of being, for the first time as I see it, semi-realized or hopefully realized for the COVID vaccines with COVAX, where 1 billion of the 2 billion doses that COVAX promises to provide in the near future, once a vaccine is there, obviously, 1 billion, that is 50%, is for low and middle income countries. And that is obviously because different richer states, high-income countries, pay for that. It is clear that vaccines show a lot of benefit because they reduce costs for treatment, etc. And I think that this should be taken up for all the other vaccines in a way like Gavi had started it. And I think that is a way. Now to the kind of more basic mechanisms, is that right, what you asked me, Stefan?
Well, is there any common approach?
Talking about viral vaccines, which obviously is very, very important, where antibodies are extremely important. Antibodies is a very precise system. Typically, it would, let's say, neutralize a toxin, it neutralizes attachment, etc. And then come T cells in play. And I would argue that some vaccines need to focus strongly on T cells, TB, HIV, malaria, and antibodies, both. There, this precision mechanism is not that important, as you know, and immunologists are aware. A T cell recognizes an infected cell and then either kills the cell or activates mechanisms that kill the bacteria or the viruses. And in this case, it's not so important that this is an attachment factor, a virulence factor, but it's broader. So all the and that comes in mostly when you think of viral mutation or pathogen mutation. So I think T cells, and the story of HIV, malaria, and TB has shown, T cells and antibodies are needed. And I think that is the way to go in the future again, to consider antibodies with their high specificity and requirement for specificity, and of course also the T cells. And that is nothing new for those in the field, I guess, but I think we have to clarify that also for COVID-19. Ultimately, T cells will be very important.
Okay, I think we'll have to stop here. I'll thank everybody for very interesting and very informative talks this afternoon. I'll thank the audience for giving us some questions, and I think they want to move on to the next session right now. I think we've seen signs of hope, and I truly believe that this inspires some confidence. So stay healthy and stay in touch, and all the best to you. Thank you very much.
Thank you. Bye-bye.
Bye-bye.
Thank you.
Bye-bye.